Welcome to the Frontier AETC Project Echo. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
We'd like to welcome Dr. Joanne Steckler back to Frontier AETC Echo. Dr. Steckler is one of our local PrEP experts. She's a provider here in our HIV clinic and also works very closely with Seattle King County Public Health. And this is going to be the next in our quarterly series on pre-exposure prophylaxis, and I will turn it over to you, Joanne.
Thank you very much. So I apologize, first of all, that I'm a little bit sniffly, so hopefully that won't interfere too much with my talking. Thank you, Kent. So again, as Brian mentioned, we're going to go through now in the next few talks that I do about some concerns that providers have about PrEP. And this first one we decided to do was going to be about adherence. So the topics we're going to talk about are, quickly, I'm going to review the importance of adherence, the efficacy of PrEP, and then give some information about how to monitor and promote adherence to PrEP. And then Brian asked me to talk a little bit about how to incorporate data and questions about intermittent dosing. So just to quickly review, these are again the list of all of the randomized clinical trials that showed that PrEP was efficacious. I include this only for your reference, but again, I want to bring you back to this table that I've shown you before that lists in order the efficacy of these trials, shown in this column here, first column, compared to the proportion of subjects who had blood drawn and had detectable levels of tenofovir. And so what you can clearly see in this table, and if you remember the figure that I often show, there's a nice relationship between, in those studies that had subjects had the highest proportion of blood specimens that had tenofovir detected, those were the studies that in the intention to treat analyses had the highest efficacy. In those studies, such as the studies that were stopped because of futility, that had the lowest proportion of specimens with blood levels detected, those were the ones that showed no efficacy of PrEP. And I'm just as one more example of this, I want you to remember IPREC study, which was the study of about 2,500 men and transgender women who have sex with men that was done in the US and some other countries around the world, that the overall efficacy in the initially reported modified intention to treat analysis was 44%. And of the samples that were looked at, only about a half had any drug levels detected. But when they looked at those people who had detectable blood levels and the protection of that, having any drug level detected, so either of tenofovir or of M-tricytidine, either in free or intracellular levels, the protection was over 95%, again, compared to 44% of the modified intent to treat analysis. Going back to the PrEP works if you take it, PrEP does not work if you don't take it. So as we transition from placebo-controlled randomized trials to open label extension and then implementation, there's a real question about what is adherence going to be in the real world. Now we know that PrEP works if you take it. People are probably going to have different motivations for taking it. Now they know it works, so they're probably more likely to take it. And that's really been shown in these open label extensions. So in IPREX-OLE, again, adherence being about 50% in the randomized trial now is about 70%. And in the trial that was reported by, it's called the Demonstration Project that I'll go into a little bit later, by Al Liu, who's based in San Francisco. This was a study, open label implementation project funded by CDC in San Francisco, Miami, and DC, that adherence by blood levels was estimated to be over 80%. The interesting thing that's come out of IPREX-OLE is what you see in this table, that they looked at the estimated number of days that people were taking their tenofovir based on drug levels detected in dry blood spots. And if there was no tenofovir detected, that the estimated incidence in this open label extension was about 5%. This was reduced if there was enough level detected in dry blood spot that they estimated that they were taking 1 or 2 tablets a week. That incidence was reduced by half. But I think what you're going to have questions about is in the group that took what was estimated between 4 and 7 tabs a week, that there were no HIV infections reported. This sort of has translated to some recommendations that you have to at least take 4 doses of Truvada a week in order to have full efficacy. But of course, Truvada is currently only FDA approved for daily use. But this is something that's probably going to come up in conversations that you have with your patients. So again, PrEP works if you take it. So how do we encourage our patients to take it? This is the recommendations from the guidelines. The full reference is in the back, but you can see in the back of these slides, but this is the reference here, that the recommendations have us doing adherence counseling every 3 months. What does that mean? So first of all, we have to figure out if our patients are actually taking their medicines. And we're going to go back a little bit to the IPREC study to say, how do we ask our patients, how do we find out if they're actually taking their medicines? And the first table that I'm going to show you is 510 of the 2,500 subjects who had blood levels drawn for tenofovir or emtricitabine. And it's like a little bit of a confusing table, but what this says that of the people who everybody was asked to self-report their adherence to the provider, do a CASI, so entering their adherence on a computer, and they also did some pharmacy refill data and pill counts. So 55% of those 510 subjects reported that they took every single pill. 22% reported 90 to 99%, and you can see the numbers decrease. So about half are reporting that they never miss a single dose. On the CASI, as we know, people are a little more honest with the computer than they are with talking to people, that slightly fewer report taking every single one of their doses. And then interestingly, by pharmacy data, people appear to be, again, doing very well adherence. But of course, we know, based on blood levels, that people were over-reporting. This was true in IPREX. This was true in basically all of the other randomized PrEP studies. That in this little sub-study, that of those subjects reporting 100% adherence, only 50% had any drug levels detected, and 35% had drug levels consistent with regular dosing. So people in these randomized trials very clearly have over-reported when you ask them how they're doing on adherence. I think what I'm going to show you is a little bit less pessimistic from the open label extension. So the next few slides are slides that I borrowed from Al Liu, talking about, again, the demonstration project that occurred in San Francisco, in Miami, and Whitman Walker in DC. These were selected because their populations of men who have sex with men had an incidence of over 2%, and there were people both seeking PrEP as well as referred for PrEP. They did very similarly to the randomized studies, very intense evaluation of how adherence was, how people did with adherence. So they did a self-reported adherence scale, they did a pharmacy reports, and they continued to have people do dry blood spots for levels of drug. And based on these levels that were found in the dry blood spot punch, they estimated that people were taking either 4 doses a week, 2 to 3 doses, no 2 doses, less than 2 doses, or not taking it all. And what I want to show you is basically that in contrast to IPREX, in which 50% or so of people had detectable levels, that this is the 80 to 86% that Al reported, that in this subset of people who had their levels determined by dry blood spot, that they actually were taking their protected level, so not just any level detected. And again, in contrast to what we said, what I showed you in the table, that there was a huge discrepancy between what people were reporting and blood levels detected, that reporting at very good or excellent adherence was sort of in the 80%. So what I want to show you here, and what I'm being less pessimistic about, is that self-report isn't as bad in open label extensions as it might have been in those randomized trials. And I say that because as we move into, and this slide is just for your benefit, just to show who had lower levels of adherence as determined by dry blood spot levels. And in this demonstration project, it was Miami. African Americans were less likely to have dry blood spots with protective levels. Folks who had stable housing were more likely to have protective levels, not surprising. And interestingly, if you had a greater number of sex partners with whom you had condomless sex, you were more likely to have protective levels. What we've seen in the past, so people who are having more risk are more likely to be taking their PrEP. But again, going back to the sort of my less sort of pessimistic sort of interpretation of self-report, is that we don't have a lot of options in the clinical real world about how to monitor adherence. And so these are my strategies of sort of how I assess whether or not my patients are doing well on PrEP. The first is, are they showing up? Because many times we have people who show up for their initial appointments and then they don't show up again. And so if someone doesn't show up after 3 months, despite a call and reminder for them to come in, I know they're not taking their PrEP. Similarly, we have some people who never actually pick up their prescriptions. They don't show up. I check to see whether they've actually filled the prescription, and they never picked up their prescription. And so these are sort of the very blunt tool. And in contrast to our folks who are HIV positive, who we will chase in order to get them back in care and get their viral loads undetectable, at least my practice is not to chase people who are on PrEP in order to get them back on PrEP. There's less of a public health risk for someone who is HIV negative and on PrEP. There's obviously a huge individual risk, but I feel that people have their own autonomy. The other downside of PrEP, of course, is that we don't have viral load monitoring, which people can use as an adherence monitoring tool. You know that your patients who have detectable viral loads either have drug resistance or they're having adherence issues. We don't have that for PrEP. So in terms of what you really can do, I think we take what we've learned from our HIV positive patients in terms of how do we assess and monitor adherence. And what I typically use is, how have you been doing and how many pills have you missed in the last month? People are likely going to overreport their adherence, but this appears to be one of the best correlations. You know that if someone is telling you that they've missed several doses in the last month, they're probably having some problems, and you can try and help them focus more on strategies to increase their adherence. Some use how many pills in the last week. I think that's less useful than how many in the last month. And if you're doing surveys or computer tools, you might consider the last question, which is a qualitative measure. How good has your adherence been over the last month? And give them the qualitative options of very poor, fair, good, very good, and excellent. And that, at least in HIV positive folks, seems to be one of the best measures for adherence. So that's how to monitor. So how to promote. So one is, how do we assess how well people are doing? How do we promote adherence? And again, most of these are completely based from lessons we've learned over the last few decades with HIV positive individuals. So at that initial point, you're going to talk about PrEP, what PrEP is, what the side effects are so they know to expect them, and how important it is to be taking their medicines every day. We talk about how to establish a routine. So, everyone has their own routine about how they remember to take their medicines in terms of what time of day they're going to take their medicines. Personally, I take my medicines when I brush my teeth. I find that that's helpful. Other people take it with their breakfast. Other people do other things, whatever fits best with them. And I think it's really helpful to try and personalize that. We often talk about what to do if you miss your doses. So if you take your dose at night and you realize the next morning that you haven't taken it, with PrEP, we tell people same thing with HIV. So if you remember in the morning to take it, and you typically take it at night, go ahead and take that missed dose. The worst thing that's going to happen is that you're going to have potentially a little bit of extra side effects, but in general, PrEP has very few side effects, and so it's probably not going to cause any problems. If someone doesn't remember until it's time to take their next dose, you tell them to skip that dose and reinforce the fact that PrEP is a little bit more forgiving than HIV. The data suggests, again, that you really have to be taking at least 4 times a week. So it's really important to reinforce that if people miss a dose, it's not the end of their world. Still, again, PrEP is FDA approved to be taken every day. We recommend that you take it every day, particularly because if people try and do intermittent dosing, there's good data that suggests that people aren't as well covered for their risky exposures, so they're actually less likely to remember to take it overall. So again, baseline, talk about reminder systems and tools. Is it a phone? And we'll talk about that in the next slide. Talk about financial, substance abuse, and mental health needs and barriers. Financial, of course, is going to be one of the biggest things, and we've talked about that in other talks. And facilitate social support. Again, these are recommendations that are in the guidance. And then during follow-up, ask them how they're doing. Talk about barriers, particularly if someone tells you that they're having problems. Try and problem solve with them, just as you do with your folks who are HIV positive. Assess and help manage side effects. The majority of people aren't going to have side effects beyond the first couple of weeks. Of those people who have side effects, they're going to be mild, but there are going to be a few people who are going to have persistent gastrointestinal side effects that you might elect to continue PrEP with and try to manage those. And some people may need to discontinue because of either symptoms or because of abnormalities in their labs. Again, normalize that it is okay to miss an occasional dose and reinforce how well people are doing, because again, most people are doing their PrEP pretty well. I just want to sort of go through a few of what the tools are that are available to us right now. Just as with HIV positive folks, there are Medi sets that people can buy at the pharmacy that are very inexpensive. People use alarms and reminders, like alarm clocks, like their phones, like their smart watches are a new thing coming up. There are providers who are using text messaging and emails, and if you may be able to routinize that as part of your practice, that may be helpful. There are several studies that suggest that patients like getting those routine text messages and emails, and they find that it helps with their engagement. There are a lot of apps that are available, free apps that allow people to monitor their own adherence, similar to sort of the Fitbit idea. You sort of monitor yourself and encourage yourself and try to encourage yourself to increase your adherence. And then what I'm showing you here on this slide is MedMinder. Many of you may have seen me talk about WisePill. This is a very similar device. It's a Mediset, as you can see. And basically what this does is when you open your first dose on Monday or on Sunday, when you open it, it sends a signal to a server, and your provider or your patient can look and actually monitor your adherence. And similarly to WisePill, if the device isn't open at a specific time, that it can send a text message to remind you to take your medicines. This is currently now available in the United States. So WisePill, which has been used in research, is not yet available, but MedMinder is currently available and requires a service plan of about $40 to $60 a month. So it's not inexpensive, but there's some suggestion that insurance companies are going to start paying for this. I'm not certain about for PrEP, but potentially for HIV and other chronic conditions. So I think just quickly, if you want me to talk about on-demand and intermittent strategy, I have up here the strategy for IPERGAY, which was the randomized study that was looking at intermittent strategy, in which participants randomized to the strategy took 2 Truvada tablets 2 to 24 hours before they had sex, and then 1 tablet 24 hours later and another 24 hours later. So the thing about this is that it requires you to take your medicines before you have sex and know that you're going to have sex. But as many of you know, it was highly effective with an efficacy of 86%. There was quite an amount of risk in this group. So it's unclear, I think, looking at this, whether or not the strategy really was daily dosing or it was intermittent dosing. So I think there are a lot of people who are reluctant to prescribe this. Again, Truvada being FDA approved in this country only for daily use, but there have been a lot of questions about this. The other concern I think I have is how far in advance do men plan for sex? I've showed this slide before, and this was a number of MSM, men who have sex with men, who respond to when they knew they were going to have their last sexual event. 50% didn't know until it was happening. 10% only knew minutes before. And so about 30 or 40% knew hours enough that the intermittent strategy might have utility for them. However, again, there is good data from studies when you look at intermittent strategies versus daily routine strategies and look at the proportion of sex events that are covered by adequate drug levels, that you get better coverage for people who are taking daily doses. So I still recommend daily coverage and not advocate intermittent strategies unless someone is really adamant or has really infrequent risk. And I believe that is my last slide, with just showing you the reference for the guidance and then any questions.